Hi, this is Marianne Ward. This is assessment video number 2. We're going to talk about chest, heart, lungs, circulation, etc. Alright, and I just want to thank my patient today for being so kind to assist me. Okay, so we're going to start by examining the chest, and I'm going to have you sit up, please, turn around, and drop the gown. So first of all, we're going to look at the chest, and what we need to focus on here is just to examine it, that the anteroposterior diameter is less than the lateral, which in this case it is. Time that it would not be the case is when a patient has COPD over a long period of time. They tend to develop a barrel chest. The diaphragm is pushed, everything moves forward, and then their chest protrudes even further. So in this case, my patient here is normal. So I'm going to grab my stethoscope and warm it up. I'll be kind, I promise. And we're going to listen to some breath sounds. The best thing to do is start at the bases and work up, side to side, work up. One of the reasons for that is when patients have any respiratory issues, the diminished sounds will be at the bases. The problem will be at the bases. So in order to prevent fatigue, you want to work your way up. So I'll warm this up. Now, I will tell you my patient can be a little bit of a comedian, so please bear with me. Okay, so what I want you to do is breathe through your mouth. I want you to bring your arms across and lean forward just a little bit. And take some slow, deep breaths through your mouth. Do not hold your breath. Okay. In and out. In and out. Nice deep breath. Okay, that's it. Breath sound should be clear. Some of the things you can find besides diminished breath sounds would be rhonchi, crackles, wheezes. Nice and easy. A couple more deep breaths for me. Deep breath. Nice deep breath through your mouth. Alright, I'm going to come around to the front. You can bring your arms down. And a couple more deep breaths. Okay, breath sounds are nice and clear. Alright, moving right along. Sorry. Alright. Okay. I'm going to talk a little bit about respiratory distress and what we might look for in a patient with respiratory distress. Patients may exhibit a couple of things. You know, there's some things that you auscultate, which would be, again, the crackles, rhonchi, wheezes, and then there are the things that we visualize. Nasal flaring, pursed lip breathing, cyanosis, children especially, we will see the use of accessory muscles. So these are some of the things that you would see when someone presents with some respiratory issues. I'm going to move on now, and I'm going to check pulses. So I'm going to have him lie down for part of this, but right now I'm going to start by checking the carotid pulses. It's always best not to do that at the same time. You should not press on both carotids at the same time. You can cause a vagal response, cause their heart rate to drop, and then you have a patient lying on the floor. I don't think you want to be on the floor, not yet. All right, carotids are nice and strong. Radial pulses. Another thing that can be done is to check at the same time, palpate the chest, check the carotid at the same time. All right, sounds good. Okay, I'm going to have you lie down. Okay. And check femoral pulses. I'm going to do that one at a time. Nice strong femoral pulse, and then move up to this side. Okay. Popliteal pulse. Post-tib. And peel. And of course I'll repeat it on that side. Now for patients who have poor circulation and weak pulses, you can also use a Doppler to check pulses. Okay, while I've got him lying down, this is also a good time to check for edema. So I'm going to check for edema. I'm also going to check for venous insufficiency and arterial insufficiency. So edema, it's evident he does not have any. Okay, but of course, the best place to check, furthest point from the heart. And this is where patients tend, even patients who are healthy, I myself being one of them, after 12 to 14 hours on my feet, will definitely have edema to my feet and ankles, especially when I've been standing in one place for a period of time. So you want to check along the bony prominences for any depressions. Edema is in degrees, 1+, 2+, pitting, and of course pitting edema would be where a depression would remain in place even after you're done pressing. Venous insufficiency. Some signs of venous insufficiency would be varicose veins, venous stasis ulcers, which will open up usually on the medial malleolus. Can also be on the lateral, but is very frequently found on the medial malleolus. Another thing I'm going to look for while we're checking for venous insufficiency is the Homan sign, which is indicative of DVT. This sign is a good indicator of DVT. However, if the sign is negative and the patient does not have pain, it's not proof that the patient does not have a DVT. So I'm going to bend the knee and just relax. Relax, relax, relax. Bend the knee and dorsiflex. Any pain? All right. And we'll do the other one. Bend the knee, dorsiflex. Okay. No pain. As far as arterial insufficiency, oh, sorry. Arterial insufficiency. Some of the signs we look for with that are shiny, hairless skin, which this patient does not have, mottling, and then claudication, which is pain that occurs with activity and will go away with rest. So when you walk, sir, do you feel any pain in your legs when you walk that is alleviated by rest?
No, ma'am.
No. All right. Okay. All right. So the next thing we're going to do is some vital signs, most particularly blood pressure. I have the standard cuff. I'm not going to use the electronic cuff. I'm going to use the good old-fashioned sphygmomanometer. I'm going to take blood pressure in both arms. Now, blood pressure, back in the day when I was a new nurse, blood pressure, patients were told that blood pressure, you were hypertensive when you reached 140 over 90. 140 over 90 these days is serious. Once a patient is over 120 over 80, in today's terms, they are now considered pre-hypertensive. Blood pressure will vary from one arm to the other, but the biggest variance you're going to get, of course, is in systolic. Systolic blood pressure is very labile, so it can elevate with caffeine, with just having a conversation, with anxiety, but your diastolic blood pressure should pretty much stay where it is. After I take his blood pressure lying down, I'm going to have him stand up and recheck his blood pressure. This is to check for orthostatic hypotension. Patients with orthostatic hypotension are those patients, or those that may have it, are those patients who are on blood pressure medication, who have told you they've had episodes of fainting, or patients that tell you that they get dizzy when they stand up very quickly. It can also be caused, orthostatic hypertension can also be caused by blood loss, even something as simple as a blood donation. It can be caused by your antihypertensive meds or other meds, and also a GI bleed. So let's do blood pressure. Okay, this arm was 132/76. That's high for you. Usually runs in the 1-teens. Okay. Okay, 128/72. So, 132/76, 128/72. So, now, I'm going to swing around. I'm going to get you tied up real fast here and have you stand up. Sorry. This should be done fairly quickly in order to get the effect. Okay, up you go. Okay. 122/80. So this is normal. What happens when the patient who does not have orthostatic hypotension, when they stand up, the systolic may drop or stay the same, and the diastolic goes up just a tad. So that's exactly what we're looking at. In orthostatic hypotension, you will see a difference of 15 millimeters of mercury or greater. Okay, 128/82. Thank you, sir. All right. Have a seat. I'll give you your blanket back. Sorry. And just have you and just have you sit up. We're going to go ahead. We're going to go ahead and while he's sitting up, I'm going to drop the gown again. And and listen to his heart. And he does that one. Don't look at me like that. All right. The stethoscope is warm. All right. Now, what I want you to do is breathe in and out normally. And when I tell you, exhale and hold your breath. I promise I won't make you hold your breath for long periods of time. So just breathe normally. And for exhale, hold your breath. Okay, breathe normally. Exhale, hold your breath. Breathe normally. Exhale, hold your breath. breathing normally. Exhale, hold your breath. Breathing normally. Exhale, hold your breath. Okay. Normal heart rate, regular, no extra beats, no unusual sounds. Things that we're looking for would be irregular heartbeats, a regular heart rate, any swooshes, clicks, any murmurs. I still remember the first time I listened to a patient's heart that had an artificial valve and almost jumped because of the obvious click. We're also looking for more of a clear sound rather than muffled heart tones. So all of that is present. All right. No, I'll leave you undone. Congestive heart failure. Some of the signs and symptoms that a patient will have when they present with congestive heart failure would be fatigue, shortness of breath, tachypnea, tachycardia, cyanosis, edema, sometimes, generalized edema. They will also have crackles in their lung sounds from the fluid buildup. So these are some of the things that a patient would experience if they had congestive heart failure. Lie down, please. All right. Moving right along. All right. Moving right along to, we're going to look at the abdomen. There's a couple of things I'm going to do. I'm going to look at the abdomen overall, do some palpating, some auscultation, some percussion, and I'm also going to demonstrate location of some of the vital organs and also attempt to palpate those organs. All right, so gown comes up, patient stays draped. All right, okay, I'm going to lay you flat. All right, are you okay? All right. Okay, so overall, look at the abdomen. I'm going to just palpate a little bit. No tenderness, any problems, anything hurt. Okay, 4 quadrants to the abdomen, basically. Left upper, right upper, left lower, right lower. I'm going to just have a listen in all the quadrants. I'm just looking for normal bowel sounds. You're going to hear, you may hear gurgling, you may hear nothing. Patients who are hungry, have just eaten, have some irritable bowel, you may get a lot of noise, which is called boborygmy. You may have, if patients are having GI issues, bowel obstruction, you would hear a tinkling bowel sound, or you may hear nothing. If you have 0 bowel sounds and a very rigid abdomen, this is cause for immediate concern. All right, so I'm just going to gently press. Just normal gurgling, nothing out of the ordinary. Just off topic, it's one of the things I love to do with little kids. Give them the stethoscope and let them listen. They think it's hilarious. Anyway, okay. So, here, under the diaphragm, on the right side, this is where the liver is. The spleen is tucked up under here, and the stomach is pretty much right here. So when your patient's telling you they have pain here, of course, and they have a stomach ache, no. The epigastric pain is the stomach. Anyway, all right, one thing I'm going to do is elevate this just a little bit, just so I can get a better handle on this. All right, what I'm going to attempt to do right now is palpate the liver. So I'm going to reach under with my left hand, and I'm going to push up. Just relax. Try to relax. Try to relax. Okay, take a deep breath, exhale, and hold your breath. All the way out. All the way out. Okay, I'm going to lift, and I'm going to push. What I'm feeling for, or what I'm trying to determine, is if there's any irregularities, any nodules, and I am feeling nothing. Am I hurting you? Okay. All right. Okay, just relax. Take a breath. Now I'm going to check for the spleen. If I can feel the spleen, it's enlarged. So I'm going to reach over and do the same thing. I'm going to elevate. I need you to take a deep breath, let it out, and hold. All right. And I'm feeling here. Okay, I'm going to have you come over on your right side. We're going to check for this a little more on the spleen. All right. And I'm going to do that same thing. All right, deep breath. All right, let it out. And again, if I can feel it, it's enlarged. Okay. All right, go ahead on your back. All right. Okay. I am going to talk about some signs of peritoneal inflammation, problems, and in fact, I'm going to have you get up for the one, so let me get you that covered up. Some of the signs of peritoneal inflammation would be a rigidity of the abdomen. I was already checking for that, and as I said, if the abdomen is rigid and you have no bowel sounds, you have a serious problem. Other problems are rebound tenderness, so I'll demonstrate that after I have him do the heel jar test. So I'm going to have you stand up, face me. What I want you to do is come up on your toes and come down hard on your heels. All right, any problems? No tummy problems. Okay, go ahead and lay back down. And do a couple other things that would indicate any peritoneal inflammation. Okay, rebound tenderness. All right, so rebound tenderness is you press and the patient does not have pain. Let go and they have pain. Hence rebound tenderness. Excuse me. Another problem would be, or another indication that there's an issue, would also be left or right lower quadrant pain when you are pressing down on the left lower quadrant. Yes, peritoneal tenderness. Okay, we've covered the rigidity, the positive heel jar test, rebound tenderness. These are all signs of peritoneal inflammation. I've got to do one more thing. I'm sorry. I keep having you get up and down, up and down, up and down. Just sit on the edge. Okay. I'm going to drop the gown one more time. And we're going to do some percussion for CDA tenderness. And all I'm going to do is come here. All right. Now, this should not cause pain. Patient should feel a thud, and that's about it. Okay. So. Pain? Oh. Okay. All right. I believe that wraps up our heart, lung, abdominal video. Thank you.